John Smith, Mr. Ray Gregson, and our board secretary, Ms. Shelley Babineau, along with Ms. Michelle Tate. At this time, I'll turn it over to Darrenisha, and she can lead us to.
All right, good afternoon, everyone. My name is Samantha Buras. I'm the insurance technician for St. Charles Parish Public Schools. Thank you all for your time and joining us today. We will receive a presentation from Humana on the annual Plan Pulse Report, which will provide an overview of member utilization and key insights into the Humana Medicare Advantage plan's performance. Joining us today beside me, we have Ms. Darrenisha Gray, General Counsel and Director of Risk Management and Benefits. From USI, we have David Babin, Employee Benefits Broker, Jesse Babin, Senior Vice President. And from Humana, we have Ms. Jody Hagewood, the Senior Account Executive. She will be joining us virtually today, and Ms. Mia Basaraj, Clinical Pharmacy Lead. We appreciate everyone participating in today's discussion, and I will now turn it over to Mia to begin the presentation. I'm sorry, we'll turn it over to Ms. Jody Hagewood.
Sorry about that. I'm going to take that over. I'm going to start us off. Thanks so much. Can everybody hear me okay? Okay, perfect.
Yes, we can hear you.
So I'm going to start us off. Again, thanks for having us today. Sorry I'm joining you by phone. I'm glad Mia could be there in person. So our agenda today, we're going to talk about NPS and customer service. We'll talk about a few benefit updates for 2027. We'll touch on the CMS final rate notice. I'll go through the medical plan compass, and then we'll have Mia go through the pharmacy plan compass and talk about some IRA and pharmacy updates. Can go ahead and go to the next slide after that. There we go. So this is our Net Promoter Score. The Net Promoter Score is a measure of how likely our members are to recommend Humana to family or friends. And so for St. Charles Parish School Board, you have an excellent score. So 84.87 is actually world class. So anything over 70 is considered world class. You all are very much above that, which means we're giving your members great experience. They're very happy with Humana. Our overall group Medicare book of business is 72, so well above that. So very happy to see that. I'm gonna go to the next slide. So here we're just talk about our annual calls report, and this is going to be for all of 2025. So the green line is going to be the plan year of 2025 and the previous year of 2024. And you can see really, I mean, pretty consistent over the year of the number of calls that we get. So if we go down to the bottom left, the top call drivers, number one being benefits. There were 315 calls for benefits, 197 for RX, and then 124 for authorization referral. These are typical top call drivers that we see across all lines of business. And I would say still for the year, very low call volume. And so over to the right bottom is the ACS, which is our account concierge. And this is account concierge, and this is when Darrenisha or Samantha reaches out to us and somebody has an escalated issue. Our account concierge will reach out to that member or provider for resolution. And so again, very low call volume there. We only had 5 for the year for provider, 2 for benefits, 2 for claims, 2 for RX, and then just a couple of stragglers, dental and eligibility and out of network. So very low call volume overall. So your members know how to use the plan. They're used to the plan. They've been on it for a long time. So those are all great metrics. We can go on to benefit updates. You can skip 2 slides. go to the benefit update slide. There we go. Then one more. Here we go. Okay, so beginning in 2027, ANOC, we use a lot of acronyms at Humana, but the ANOC stands for the Annual Notice of Change. So we send this out every fall, letting members know of any changes for the upcoming year. And for 2027, those members who have opted into receiving their annual notice of change electronically and have a valid email address on file will begin to receive those ANOCs digitally. So only if they have opted in to receive communications via email will they get them. If they have not opted in, they will just go ahead and get them by mail. But if that is a preference that is selected, they're going to get them digitally. And then also new for 2027, we are aligning more with the industry, and we are going to have a 100-day supply RX. This just promotes better medication adherence. So minimizes that late to refill gap. So if they realize after their 90-day supply is up and they need their medications and they haven't put the refill in, then they still have those additional days. Also for 2027, we're going to members will be able to get their continuous glucose monitors at Centerwell, which is our Humana mail order at $0. So actually, this is not going to have a big impact on your members, as when they get their diabetic supplies through Centerwell, they do have a $0 copay.
Thank you, Ms. Hagewood. Before you move on to the next section, I just wanted to open it up for any questions regarding the 2027 updates. All right, thank you. You can proceed.
Thank you. We'll go on to the CMS final rate notice. So the final rate notice was published April 6th of 2026. CMS, Centers for Medicare and Medicaid Service, indicated that the proposed changes are expected to yield a net average payment increase of 2.48% year over year. So this is more favorable than initially proposed, which was initially 0.9%. So while this is more positive than we thought it was going to be, it does not still fully offset, rising medical and pharmacy costs and those industry pressures. Specialty drugs are getting more expensive, high-cost therapies. And then, of course, we have the Inflation Reduction Act, which you'll hear us talk about quite a bit through this, that's really continuing to affect prices across all carriers. And then the proposed Part D parameters, so this is set by CMS. So for 2027, that will be $2,400 for that out-of-pocket threshold. So if there's no questions, we'll dive right into...
Ms. Hagewood, just for informational purposes, will you just briefly touch on what the out-of-pocket threshold was for 2024 and 2025?
So for 2025 is when the IRA went into effect, and then it was $2,000. And so currently it's $2,100. And then in 2027, it's going to be $2,400.
Thank you. And what was the out-of-pocket for 2024? That way they'll just get an idea of the impact of the IRA.
Mia, do you have that? That was pre-IRA, so
Yes.
Everything was a little bit different. Mia, can you touch on that?
Sure. Good afternoon, everyone. Thank you for allowing us to be here. The 2024 out-of-pocket was $8,000.
Thank you for providing that information.
Thanks. Okay, so we're going to talk about, I'm going to dive into the medical plan compass and just a little bit about this. So this report represents utilization for January 1st through December 31st of 2025. So we report your current period data beside your prior period data. So you'll see current and prior. And then we also use our peer group. And the peer group allows you to see how you compare to our group Medicare book of business. So the peer group is going to be our group Medicare book of business, excluding St. Charles Parish School Board. So on this page, we're going to just go over the member snapshot and engagement. So the membership increased 153 members, which was a 19.6% increase. The male-female ratio did not have a significant change, and is also the average age, also really not a significant change, and is very much in line with the peer on the average age. Participation in silver sneakers continues to be consistent for 23% for both current and prior. And your members are participating more than our peer group.
Thank you. And I also wanted to mention too, the reason for the big increase from the prior to the current year was due to, if you can recall, January 1st, 2025, we had that transition of a group of retirees off of the UMR WRAP plan and onto the Humana Medicare Advantage plan. Yes, sir.
Great, thank you for that. Yes, that's good information to know. So member contact engagement information. So the percent of members with phone numbers on file did go down about 3.3%. Still a great number of 95%. Number of email addresses increased 0.8%, 28% higher than the peer, and 82% of members have registered on myhumana.com, which is a slight decrease, but still much higher than the peer. And I will say our target for myhumana.com registrations is 30%. So your group is doing a great job of staying engaged and having all of their contact information on file.
Jody, when the enrollment happens, since the retirees enrolled directly with Humana, are the reps asking for that contact information as a requirement, at least a phone number or an email during that enrollment?
I'm sorry, can you say that again? I can't hear very well, so I'm trying to listen.
I apologize, I'll get closer to the mic. Because the retirees are enrolling directly with Humana and not with us, when the representative meets with the retiree to enroll, is there a requirement that they have to provide a phone number or an email as part of the enrollment?
So it is not required, no, but what there is, when you send over files, we do request that information on there. And then as members call in, and if there's not something on file, we do ask them if they would, prefer to have that on file. So we try to collect it that way, but it is not a requirement.
Thank you.
I think we're one slide ahead. 2, 3, yeah. Can we go back to slide 15, please? There we go. So preventive visits are really important for this demographic. So it's great to see that your members are doing a great job with their preventive visits. 79.8% of members received preventive service during the reporting period, which is an increase of 1.6% and really right in line with the peer. When compared to receiving at least one preventive service increase from 10, receiving at least one preventive service increase from 10.1 to increase 10.1%. So that's great to see. As we look over to that bottom right, the plan's current preventive service rates are higher than the prior period for preventive office visits, although lower for the peer. Breast cancer screenings went down 3%, but still higher than the peer. And then the pneumococcal immunizations, those are only recommended once in a lifetime. So that doesn't typically change too much year over year, as well as your colorectal, because that's only, again, once over a period of years. So there's typically not much change in either of those categories. So now we're going to talk about clinical programs. So our first one is care management, and this could be post-discharge support, medication therapy management, chronic condition management. So this assists members with medical, behavioral health, social determinants of health issues. We identify those members that have the highest need for intervention based on inpatient admission and readmissions, and referrals. So we stratify them based on health needs. And the highest patients and those with acute needs are assigned to then an integrative care team, which could be a nurse, pharmacist, social worker, or an emotional health specialist who will support them. So there were 25 total eligible in the year and 13 participated with 52%, which is an increase from the year before. So that is great to see your members engaging in that. And then when you look at transplant, the participation is always going to be 100%. So this is a transplant team that is with them from beginning to end. So they're during the planning stages, through the procedure, and then 1 year after post-transplant. So we always see 100% participation there. On the in-home health and well-being assessment, this is when we use a third-party vendor and they do come into the home. Screenings are based on health, age and health status. They can give education, information on health conditions, medications, and preventive care. They can also help with referrals and connect patients to available resources. They can really help with address specific health and social needs. They can also do medication management. So reviewing their medication list, educating them on the side effects. And also what I think is most important is social determinants of health, which is hard to see when you're in an office. But so when these come into the home, they can identify social needs that can be barriers to achieving better health. That could be food insecurity, social isolation, loneliness, or transportation. So the participation for 2025 was 19.9%, which is just a little bit lower. So we do like to encourage that, but not everyone likes to have someone come in the home, but that is there for them.
Thank you, Ms. Hagewood. And I'd also like to note that I do receive several calls from members on this, as they are a little leery and allowing strangers into their home. So my question to you, is there any board-facing materials that you can maybe send to Ms. Gray and myself that we can provide to members to reassure them that it is affiliated with Humana Medicare Advantage, so that we can try to increase engagement in this program?
Absolutely, yes. I might have some slide in the appendix attached to this. I'll have to see at the end, but if not, then I'll definitely get that to you.
Just a quick question on that, well, really, any of them, I guess, well, except for the transplant. I sure hope it's 100%, because if it's not, the person must think they're a doctor, or they're using ChatGPT or something. Care management, the other one, or how's that compare to the peer group, or is that normal? Is it normal for this part of the country, or are there anomalies? Just curious. I don't know if you have compared.
Yes, everything's in line for sure. Yes. All of the numbers that we see here, for care management and the in-home health and well-being assessment are in line across our book of business.
Thank you.
You're welcome. So now we're going to talk about health alerts. And health alerts are there to improve member health overall, encouraging those preventive services, alerting physicians of potential drug interactions, identifying options that could reduce the risk of complication. So the gaps in care may be preventive in nature, or maybe disease specific, or related to care modifications. So the messages we provide are relevant information that can improve the member's health. And some examples could be notifying a member's provider. We flag gaps in care in our customer care portal or their member profile for clinicians if they call in. We also send out emails to those that want to receive notifications by email, and also letters. So of the top 3 disease categories for which health alerts are generated, if you look down to the third one, prevention and screening alerts had the highest compliance rate at 79.4%. And if you look at the bottom, 801 members had a health alert generated, and of those, 51% were fully compliant, meaning they had no open health alerts by the end of the reporting period. And then if you see that purple circle there, so we can see that your members had a higher percentage of compliance in most categories compared to the peer. So your members are doing a good job of responding to those health alerts and closing those gaps in care. So here we talk about utilization. So we like to see, it's positive to see, to see primary care provider utilization increasing, which is exactly what your group did. So this is great to see. We had an increase of 9.3%. Specialist visits were 6.8%. Some other things to note, for inpatient care, the acute hospital days, those were up 15.3%, although the long-term acute care admits were down 16.4%, so they were not spending as much time in the hospital. Those ambulatory surgical visits were down 3.6%. Other outpatient procedures were up 9.2%. We'd like to see that outpatient care. That's fine when we see that increase, just knowing that they're not getting it in the hospital. It's more cost effective to do it as an outpatient. And the emergency room visits were down 2.9%. And also good to see that the percent of repeat ER visits down, as well as that inappropriate ER visits down 7.1%. So those are all good numbers to see decreases in. I'll go ahead and go down to the prescriptions per thousand. So those were up 3.5%. So overall, very much in line with what we're seeing. On this page, we talk about the top 10 clinical conditions by prevalence. So the top 10 conditions account for 64.9% of your medical spend, which is down 12.1 from the prior period. So we have, you'll see over here the current rank and the prior rank. And there's really not too much a difference. A couple of them have, a couple of ranks difference, but for the most part, they stay pretty much the same. Some examples: endocrine, nutritional, and metabolic diseases. That's going to be your hypertension, hyperlipidemia, which is the high cholesterol, type 2 diabetes, hypothyroidism. These are all very typical for this age group. Diseases of the circulatory system, again, just heart disease, type 2 diabetes, stenosis of the arteries. And again, high cholesterol falls in this category. And then again, I'm sure not much of a surprise with this age group, diseases of the musculoskeletal system and connective tissue are going to be that low back pain, hypertension, localized neck pain. So those are just some examples of what those are. And the most costly clinical condition was diseases of the musculoskeletal system and connective tissue at 15.4% of medical spend. So here we are on this page, and as I just said, the top 3 conditions by spend, that number 1 was the diseases of the musculoskeletal system and connective tissue with 15.4% of medical spend, which was actually down 1.7% from the prior period. And then number 2 is diseases of the circulatory system. That was up 2.7% for medical spend. And then neoplasms, which are going to be your cancer, that's 7.9%, and that was down 2.7% from the prior year. All 3 of these, most the highest spend clinical conditions were in a large claimant category. So all three of these represent about 37.2% of your medical spend.
Can I ask a quick question? On the current versus prior on slide 19 and on the change and 19 and 20, is this the percentage of spend per person, or is it our total medical spend?
A total member spend.
Okay, so since we added, I don't know, whatever that number increase was, 150 people, I mean, the fact that we went up a little bit somewhere is kind of expected, and if we went down somewhere, that's a good thing. Well, could be a good thing, potentially. All right, does that make sense? All right, cool, thanks.
I'm sorry, I didn't hear that last part, sorry.
Good, my question, I just wanted to know if it was per person or as the whole number. Because we're comparing,
Yeah, it's not
yeah.
per person, it's-
You got 150 more people,
Yeah,
so,
overall numbers.
got it, thanks.
Yeah. I'm sorry, it's difficult to hear a little bit. I'm so sorry about that. Okay, I think we're ready for the next slide.
I'd expect it to go up a little bit.
Yes, you may proceed. Thank you. Ms. Hagewood, are you still with us?
I'm still here, yes.
You can proceed. Thank you.
I'm sorry.
You may proceed. Continue.
Okay, thank you. Yes, the next slide, please. So on this page, we're going to talk about the large claimant impact. So we'll start with the number of claimants. So there's $3 thresholds, 50,000, over 50,000, 75, and then 100,000. And so we did have an increase in all three categories. We're going to focus on the over 100,000. So that went up from 18 to 31 in the current period, and that accounts for 33.6% of your spend. So that's up about 10.5% from your prior period. When we go down below and talk about the top 10 large claimants are going to be those over 100,000, we give the top 10 and their status being active, meaning they're still with the program or they're still in the group, and then the clinical program status. So when we talk about the clinical program status, if they're a former participant, that means they had their condition and they're no longer getting treatment, or they completed the program, or they're currently enrolled. Low opportunity for impact just means that their condition, there's not much we can do for that. So those are some of those. And I would tell you on the top 10 large claimants, when I looked at these individually, these are medical and RX spend. So it's good to note which of those categories. And I will tell you the majority of these had the highest in RX spend. So just some examples: endocrine, nutritional, metabolic, some disease that affects the tendons. There was an infection in the cardiac valve, some pneumonia, colitis, cancers, and all of those, osteoporosis, all of those had a large RX spend. So of these top 10 large claimants, they account for 18.8% of your total spend.
And Ms. Hagewood, because this is a fully insured plan, I'm not sure if you can provide us this information, but are you able to tell us whether these large claimants are the primary retirees or if they're dependents?
No, we are not able to disclose that information.
in any indication or insight if you, that you can provide of these high costs, the increase in high cost claimants is driven by the population that transitioned January 1?
You know, that's a good question. I don't have that broken out. I can take that back and see if we see a difference in that. I'll have to take that back and use that as a follow-up if that's okay.
Yes, ma'am. Thank you. Okay, ready for the next slide, please. So this is a plan spend snapshot. Just talking about spend distribution by place of treatment. So the top 3 spend drivers by place of treatment outside of pharmacy are going to be outpatient care, followed by office visits and inpatient care. And then typical of what I see across really all groups, we would see is pharmacy is that top spend driver, and that's up 7.1% from the prior period. And just some additional information on the spend. So for medical, I will say for 2025, the net paid PMPM spend is up 14.9%. And on pharmacy, it's up 56.5%. So a grand total of 28.7% overall. So we have some pretty large increase in spend on pharmacy, and Mia will dive into that more in her section.
Are you able to tell us what the peer percentage is for pharmacy for your other book of business?
So we don't, yeah, peer is not available on all metrics, and so we do not use a peer since this is very group specific.
There's a question, if you can please repeat what you were previously stating about the different percentage increases with the pharmacy and the medical spend, please? The numbers that you were providing?
I'll have to follow up with this for the previous year. I will say this, just looking, going through other groups and reviews, I will say the pharmacy had a larger increase than I have been seeing. Medical is pretty much, you know, like I said, but it's very group specific, so it just depends on the group. But I can get back to you and see what it was for last year. I don't have that information right now.
Okay, the question, my apologies, the question that Mr. Gregson was asking, if you can repeat when you were explaining about the 7.1%, the 28.7%, if you can please repeat that again, please?
So yeah, so that's not on the screen. So I just, that's just information to give. So the medical for the year was just up. So the current was 1124.66. Prior was 978.47. This is net paid PMPM. And then for pharmacy, it was $755.74. And for the prior year, it was $482.80. And that's where that 56.5% comes in. Does that help?
Yes, thank you.
You're welcome. Okay, I think I'm gonna have one more slide here. We'll go to the next slide, please.
I think we have one more question before you move forward, Mr. Babin.
Okay, sure.
Hey, Jody, it's David. Can you clarify, since we're fully insured, you and I discussed, because of the size of our group, it sort of limits the amount of data that we get. Can you kind of talk about the thresholds and what we're privy to as far as information goes?
Right, we do have a threshold of 3,000 members where we provide that claims data. Anything under that, you know, just gets into too much detail that we don't like to provide out there. So maybe when you get to 1,000, we do just a light, like premium versus claims. So it won't have MER on there, but it will have what the premiums versus claims were. So if you get to 1,000, we'll be able to provide that information. If you were over 3,000, we would be able to provide detailed information.
Thank you. You may proceed.
Thank you. Thank you. Yes, that's correct. So the claim stratification, so this just shows you the claim stratification by dollars and what your members spent. So the percentage of members that spent less than $1,000 out of pocket was 97%. The percentage of members that spent between 1,000 and 2,499 was 3%. No member spent greater than 2,499 out of pocket, and 1% had no claims during the period.
Thank you. Any final questions for Ms. Hagewood before Mia moves on to pharmacy?
Well, I want to know, given all of that data that you presented.
The mic, she won't be able to hear you without the mic.
I want to know, given all of the data that has been presented, what are your recommendations? Well, having looked at all of this, where do we go? What do we need to do? And what are you recommending that we make changes in? What are you recommending that we perhaps reinforce, or just where are we?
I think I heard, if I didn't hear all of it, but I think I heard, are we recommending any changes for the next year? Maybe adding in a copay or something like that in order to reduce benefits? Is that correct?
Correct.
Okay, thank you. Yes, it would be a recommendation. So I don't think you've had, I'm new to this group just in the last few months, but I don't think you've had any benefit changes, maybe even since the inception of the group. So it's always good to assess that and maybe buy down a benefit to keep those costs down. Because you have a very rich plan, obviously, as you know, with no out-of-pocket and all $0 cost share. So I can definitely, in the renewal, recommend some changes and give a pricing impact of how that would affect the rate. So you can look at that. I can provide all that to David in the renewal.
And Mr. Smith, just to clarify, we would like Humana to prepare options on cost sharing and potential options to change the plan. Just to clarify, she was saying that we don't have any deductibles or anything like that on this plan, and we have not made changes as long as I've been here to the Medicare Advantage plan. So I just want to make sure we get proper direction from Ms. Hagewood with the renewal.
Correct.
I understand that, but we've done a pretty intensive data review. And in my judgment, the purpose of a data review is to give you information so that you can begin to start to make changes that would lead you in the direction that your goals are. And what I'm asking is, based on all of this, just, handing me this booklet of data, where do I go from here? What as the person who has the expertise in the area, what recommendations do you have? And I just need to hear some recommendations.
I think we're gonna have, once we get all of the presentation, we're gonna have to task administration to come back to us with different plans and different things that we can go through to make a decision. So, I mean, they may have to be in contact with Ms. Hazewood and others to make recommendations to us.
Well, and that's fine too, Art, but what I'm saying, this is an audit in essence. This is an audit of our health insurance program. and then the next section is going to deal with pharmacy. I just need it at the end of any audit. You know, I am accustomed to, at the end of any audit, the auditor gives some recommendations that would help to bring your program into greater compliance. And all I'm asking is, having looked at this data, don't hand me the data and tell me, here, you figure out now what you need to do to make your program a better program. You're the expert, not me. I simply say, I agree with you, and I'm gonna vote the way you say or not. So I just want to hear from, you guys. Just tell me, what are you recommending that we do? You know what our goals are. Our goal is to provide the best possible insurance program to our employees as possible at the least cost. And based on the data you have tracked, there are some recommendations you ought to have.
Can I?
And Mr.
I'm gonna say, I'm gonna jump. I think, I just wanna make sure I'm clear if I'm sorry. If I'm hearing you right, I think and I'm on the same page with you here, I believe, correct me if I'm wrong. The data we're getting is at the end to say, hey, it's working great, continue on next year, or do we make something better? Do we need to cut back? Do we need to add? Do we need or do we need to tweak, whatever, is that?
Correct.
Yeah, so I agree with that, because I was actually gonna ask, and you mentioned, Ms. Gales, that we've not changed it since you've been here, and I don't know if you know the answer, so I'm not expecting, when was the last time we changed it, or have we changed it?
And for example,
I don't know.
we looked at the data regarding the number of females who do preventive kinds of things. It's almost, double the males who are not doing it. Maybe we need to do something to get our males more involved in doing some preventive work. Are they doing the prostate screening and the colonoscopies and what are we going to do with this data other than just me being able to just rattle it off? And as the person who has responsibility for tracking this and all, I just thought I would hear some recommendations after going over the data.
Well, to your point, go to slide 21. I actually have it underlined, and maybe I'm misunderstanding terminology, I don't know. Again, I'm not the insurance expert. Where it says, on those top 10 lists, it says non-participant, former, like, I don't know if that is part of what you were alluding to, but I think that, to me, I was like, I wrote, can we require participation? I thought we required, but like, how do we get them to, I mean, that's our top 10 biggest ones. Like, it was concerning to me to see the word former, non-participant, but anyway, go ahead, I'm sorry.
Yes, sir, Mr. Smith. And to answer your question, and in defense of Ms. Hagewood, there was a partial recommendation that was provided of an idea of something that the board could do. However, we asked to withhold that because it wasn't an 100% recommendation of options to the board. And feedback that we've received in the past is when we provide just one thing instead of providing a full breadth of options. So we wanted to make sure we had the opportunity to prepare options. The second thing is we have not received our official renewal yet. So the plan and the purpose of today's meeting was to provide the board with this information and then to come back and to receive direction that we can explore different options for the plan and to come back. And that was my understanding from previous feedback about inundating the board with data and providing a lot of information. So as similar to our full self-insured plan, we've provided data and then came back at a separate meeting with recommendations. But if my understanding of that format is misunderstood, I will be happy to change it in the future, and I do apologize.
No, I don't think that you have to apologize, and I'm not looking for an apology. What I'm looking for is maybe an addendum to this report. And that addendum might say, for consideration, these are the considerations that we ask, that, and maybe list the 10 things that, just give 10 things or 5 things that the board needs to consider if the board wants to reduce your, costs. But just giving the raw data to me doesn't
Yeah.
help me at all.
I can share.
Give me an addendum to this report that lists 10 things that, you gleaned from this report that the board needs to consider. You don't have to recommend that we do any, but just give me those 10 things.
Yeah, and I'll also,
Sorry, to answer Mr. Gregson's question. So in the past 15 years, we have not made changes. I will have to go back because I'm still learning Simbly on how to get that older data, but I can find out beyond 15 years. But in the past 15 years, there have been no changes to that plan.
And
a change.
that's to the Medicare Advantage plan.
Yes,
But we
sir.
did make the change when we made our members who were on the RAP plan, if they were eligible for this plan, to get onto it, which is the 120 members you referenced earlier.
Correct.
So, yeah, so the changes were made, but not to the actual plan itself.
So for me, I know I mentioned that if it hadn't changed in 15 years, I don't need before 15. Unless somebody else does. I don't know. Please don't. That's too deep of a rabbit hole.
And Mr. Smith, just to kind of add some context from our perspective as well, the plan's fully insured, right? And so if you remember when we were fully insured primarily to reduce premium, you make some benefit changes. Correct. Right? And so I think there's 2 takeaways. One, can we educate and provide more information around preventative services, getting age-appropriate screenings? Can we educate from that perspective? The Plan Pulse report primarily is here to see what our cost drivers are in preparation of our renewal, because I'll probably have it in my inbox when I get back to the office. Our renewal is going to come out like any moment now, and all indications are pointing towards a larger than what we've seen recently increase based on a lot of the pharmacy that Mia's about to go through and a lot of the cost drivers, large claims that we're seeing. So this is kind of setting the stage for our renewal. As Ms. Gray just alluded to, Humana has some strategies to help reduce that renewal, and more of it is around how we approach administering it. So we'll be able to reduce that renewal. We'll bring that to the table. We're also going to look at plan options, adding in potentially a deductible, some copays to help bring that renewal down. So this is kind of the foundation of the cost drivers, and then we're definitely going to come back with some options once we have the renewal to show all available scenarios, whether it's plan design, contribution strategy, or some strategy that Humana's put in place.
Okay.
All right.
Can I just add one thing to that? We have gone to market to the other carriers that are in the state, so we've requested proposals from the other Medicare Advantage writers. When we get that spreadsheet, we'll spreadsheet it, we'll compare the proposals to what the renewal is, and then, as Dave said, that's when we'll come in and make some recommendations.
Thank you. That was a question I was asked next. Are we going to go back to market? So thank
Thank you all. If there's no further questions, we'll move forward with Mia.
Good afternoon. Thank you, everyone. I'm going to jump into the pharmacy reporting. So similar to what Jody went over, but related specifically digging deep into the pharmacy component of it. So next slide is fine, please. So in regard to utilization, we're going to start at the top left. Year over year, there's strong consistency in utilization. Members are utilizing the benefit. So by the end of the calendar year 2025, 97.1% of members have used the benefit or are engaging with the benefit, which is what we want. We can see that the number of prescriptions went up by 23.8%. Again, as noted prior, there was an increase in membership of 19.6%, so we do expect some of that from there. And then there's also some other impacts that I'm going to kind of dig into as well as we continue through the presentation. The total prescription per member per month was noted at 2.99. That's that second circle. This is noted to be an increase of 3.5% year over year, which is similar to the peer who landed at 2.83. When we look at the average day supply per prescription, this was noted at 58.68. This is showing a slight decrease from last year, but still higher than the peer, which landed at about 54. So this is how long members are filling their prescriptions for. So this is a good thing. We want them to fill it for longer day supplies. That translates to better adherence, hopefully better outcomes for those, chronic conditions that they're managing with those prescriptions. So that's a good thing. As Jody mentioned earlier, in regard to spend, the net paid per member per month is not listed here, but it was again at $755. This was noted at about a 56% increase from last year. This is similar to what we're seeing with our book of business. A big part of it is due to the Inflation Reduction Act and those changes in the Part D benefit design. Members being able to experience $0 cost share in the catastrophic phase has really shown a lot of increases and has been significant for 2025. And that's in comparison to the member paid per member per month, which was noted at about $23. And that was a 14.5% decrease from the year prior. This is on par with peers who also saw a decrease for their members, but they even had a higher decrease at 22.6%. So overall, the Inflation Reduction Act, which we refer to as the IRA, is really showing that costs are shifting from the members to the plan as a result of those significant changes that were implemented for 2025. And throughout this presentation, we're going to continue to refer back to that and see how those changes really impacted the plan cost share. The bottom left shows the cost distribution by tier graph. It's a visual just showing, through each tier, what is the plan responsibility. So for tier 1, it was at 76% for the plan and 24% for the members. It was also the same for 2024. Tier 2, and as you continue to go up, the plan cost share increases. So tier 2 is at 98%. Tier 3, the plan cost share is at 97%. And then tier 4, we're at 99%. So for, just in comparison to 2024, tier 1 was the same. Tier 2 had 97% plan responsibility, and then tier 3 and tier 4 were at 96. So you can just kind of see the shifts moving upward for 2025. On the bottom right, we see the prescription and plan pay distribution by tier. So when you focus on tiers 1 and 2, those two circles, combine those together, fortunately 96% of members are filling prescriptions from those lower cost tiers, tier 1 and 2. But if we compare that to tier 4, we see the gray part shows the script distribution. So there was 1% of tier 4 prescriptions, but that accounted for 43% of the spend. So although those numbers are few, they're really expensive and really contributing to the spend. We're going to dig into that even deeper when we talk about those specialty medications. The top right, before we go to the next slide, shows the maintenance medications and really just demonstrates how members are filling their maintenance medications, so their chronic condition medications. When we look at the retail 90 and mail order, it's showing 87% of 90-day supply fills. So that's a good thing. That leads to better adherence, better STARS measures, better outcomes for your members. When we look at, in comparison, the retail 30, that was about 10%. And compared to last year, the 90-day supply between retail 90 and mail order was at 73%. So we're moving up in the right direction. Members are filling more, larger day supplies, which is a good thing. Last year, the retail 30 was 23%, just in comparison. Any questions on this slide before we move forward? Okay, next slide, please. So now we're going to dig into the specialty and high-cost medications a little bit further. As you can see, the percentage of prescriptions went up about 0.8% year over year. This is on par with peers who also saw an increase, but it was at 0.3%. Now, when we look at the number of scripts, PMPM, per member per month, you see a 189% increase from last year. So we are seeing that more members are filling these more costly medications as a result of the IRA. So the IRA basically allows members to have a $0 cost share for all of their medications after they reach the catastrophic phase. So as they begin to understand that benefit, as providers understand that benefit, we're seeing that utilization is going up, and that's across the book of business. And this is driving the net paid per member per month, which isn't listed here, but there was a 291% increase for specifically these specialty and high-cost medications. So, it's two-pronged. Fortunately for members, the current benefit design, along with the IRA changes, allows them to have access to these high-cost medications that may not have been an option before. Hopefully that means more effective treatment for those disease states. But at the same time, these changes have shifted a greater cost share of responsibility to the plan. So as Mr. Smith mentioned, it warrants a review of the data to see what we can do to make sure that our current offerings are in alignment with the evolving industry landscape as these IRA impacts really significantly kicked in for 2025, and we expect that to continue for further years down the line. And just for additional perspective, there were over 4 times more members who reached the catastrophic phase in 2025 than 2024.
Say that again.
There were 4 times more members that reached the catastrophic phase in 2025 versus 2024. So when you see all these increases in the costs, it's more members that are having access to that $0 cost share, and the plan is responsible for that.
And that's largely due to the IRA
Right.
changes.
Right. And we're going to talk about that further. So there's going to be some more slides that kind of dig into that a little bit deeper as well.
So maybe if this has come up in future slides, just hold my question, but I don't know how many questions I have with this. So the IRA changes, would that have, and this kind of goes back to something maybe somebody else asked earlier, is it the new people, the 100 and some odd, the 19.6% additional that we think brought this, or could it have been some of the current, whatever that number was, that was on previously because of the IRA changes that they could have gone? My question makes sense?
Right. So as Jody mentioned, we don't have those specifics for the
Okay.
for the 19 point something that were added, but what we're seeing as far as the increases through the IRA, we're seeing across our book of business. So
Okay.
We're seeing it everywhere.
Thank you.
Right.
So it's not just it.
IRA went from 8,000 to 2,000. So before, you had to reach that threshold before you wasn't responsible anymore. Then it came down to 2,000. So everybody started getting on these drugs, and it kicked in early, the benefit kicked in earlier.
Right.
So it's kind of double-edged sword. We brought the additional bodies on for 25, and the Inflation Reduction Act took effect in 25. So we brought on more bodies, and the plan's paying more towards specialty medication at the same time.
Because I remember, and you guys remember this, when we were asking them to, or required them, the retirees on the RAP plan to go to Humana, Medicare Advantage, effective January 1st. We were discussing this, I believe, in 24. Was it? I think it was. That it was supposed to be, I remember at the time, something about whatever the max was going to increase considerably January 1st of 25. Was that was supposed to go to 8,000? Is that what we're talking about? But then the Inflation Reduction Act hit, which actually lowered what we projected back. Because we were discussing this in like February, March of 24, if I'm not mistaken. Because you and I came to a meeting here, I believe. I think. Okay, all right, thanks. Makes sense now, sorry. Came over to bid yesterday.
And we'll discuss, you'll see in later slides, that those numbers are, CMS out-of-pocket numbers, but what the members actually pay is not the 2,000, it's not the 8,000, it's much lower. So when you think about it, you'll understand further why there's so many people that are now entering that phase.
Gotcha.
Okay. All right, so looking at the bottom left, you can see the top 10 specialty drivers. You can see when you look at the drug class, it's kind of varied, kind of similar to what Ms. Hagewood was mentioning earlier. And the utilization of these drugs is really changing for 2025, as was mentioned, because there's access now. And so medications that may not have been an option before are now being utilized. So we're seeing a lot when you look at the rankings and things moving around a little bit. The bottom right goes over the specialty and high-cost pharmacies. So the local Ochsner specialty pharmacy utilization increase, it was from 16% in '24, and now it's 26.2. And then the Centerwell specialty, still showing consistent use there as well, 24.8 for this year. It was 30% for last year. So members, have access to all those programs in place for Centerwell specialty as well. Any additional questions on this slide before we move forward?
Is the Ochsner Specialty Pharmacy the hospital? You know how the hospitals now have pharmacies?
Right. So
Or is
I
that
used to
a-
work at LSU Health, which is now LSU Ochsner Health Center, and they do have outpatient pharmacies as well. But for specialty, they have special requirements and things like that. So I think they probably service more than just members at that hospital.
So is this part of the mail-in, you think, maybe?
Likely, yeah. Most of those specialty pharmacies are mail-in because they're sending things all over the place.
Because the Ochsner Pharmacy and Wellness Destrehan, obviously, that's a physical location in Destrehan. Centerwell Pharmacy, is that,
Mail-in.
and then the
That's-
BioPlus Specialty
I'm not familiar with that
I was
one.
just
I would
curious.
have to look and see.
and Onco.
Onco is mail-in as well. They have also
curious.
locations throughout the country as well that people can pick up, but most of it's mail-in.
Speak to that pharmacy. So that specialty pharmacy for Ochsner, they don't keep some certain medications in their local pharmacies, so they do ship it in. So I know that from having appointments to where they say they have to schedule it out so much time because their specialty pharmacy has to ship the medication into the physician's office to administer that
So
medication.
it's kind of like a distribution center, if you will, for okay, I understand.
For their specialty medications.
that
For
makes sense.
medications that they don't, it's not typical, so they don't keep them in this regional area, so they mail it in from, I
Appreciate
won't
it.
say it's in Atlanta, but like, let's say it's
From a
Atlanta's their hub. and
Central
they-
hub
Yes,
or
sir.
whatever, okay.
Yes, sir.
Thank you.
I was just gonna, because maybe I was just a little bit confused. When you talk about specialty pharmacies, I was thinking that you were talking about pharmacies that mix drugs and that sort of thing, sort of like,
Compounding. So it's a little bit different. So specialty medications are mainly those tier 4, very, very high cost, usually a lot of cancer medications and, psoriasis, rheumatoid arthritis. They're very, very, very expensive. So they don't keep a lot on the shelf because they're very expensive. We don't want them to expire. So they come in and they ship out, come in and they ship out.
Okay.
So it's a little bit different. Usually they cover regions. You won't see them on every corner like you see the retail pharmacies because they cater to a specific population of patients.
no, I thought you were just talking about like the compound pharmacies. And they, you have to go there and they mix your medicines and that sort of thing. Okay.
Thank you. All right, and I think we're ready to move on to the next slide. Okay, this is the most important slide. There's a lot of discussion about the $0 phase, and this is going to explain a lot of that. So this is our member by phase report. As you can see at the top, there's a key. The purple section is for the deductible phase. Green is for initial coverage. Blue is listed for coverage gap, but as you will see, there's no blue here because for 2025, as part of the IRA, the coverage gap was eliminated. And then the gray section at the top is the catastrophic phase. That's the most important part that we're going to key in on. At the bottom of that bar graph, you'll see the catastrophic members, and you see numbers under each month, and that is how many number of members were in that phase each month. Okay, so in purple, you can see that from January moving forward, the members reaching the deductible phase decrease month over month. In green, you can see from January to May, the number of members in the initial coverage phase increased each month. Then beginning about June, that number began to decline and further decline throughout the rest of the year. Now in gray, that most important part at the top, that's our members that reached the catastrophic phase, and that number increased month over month. You can see the percentages on top, and then you can see the actual numbers of members on the bottom. Now, when we focus in on that little rectangle at the bottom, it's just kind of put into perspective. So for December 2024, there were 51 members that ended up in the catastrophic phase for the year. That accounted for 6.5% of the membership. Versus in 2024, that number is 274 members, which accounted for about 29% of the membership. And to key in even more, the 2024 numbers, so these are members who reached the $2,000 out-of-pocket maximum defined by CMS. So for 2024, that actual number that members spent on average in their copays was $1,059. So although the maximum out-of-pocket for 2024 was $8,000, the actual amount that the member had to present was, on average, $1,059. So some members were lower, some members were higher. Compare that to 2025, that number dropped down to $440 in copay. So that's why we have so many more members entering this catastrophic phase month over month. And as members understand the benefit, as providers understand the benefit, they now know they can, have a high-cost medication, say in January. It costs them $200-300. If they don't have that, they can use the Medicare prescription payment plan, spread that out over the whole year. So maybe they're only paying a couple dollars every month. And for the rest of the year, all of their medications are $0. So now, for every medical condition they have, they can get anything they would like for $0. Now, in the past, I worked in primary care. There were, cost was a limiting factor. You had a disease state, they prescribed something, but they were non-adherent because they couldn't afford it. Now they know if you just pay that one time, for the rest of the year, you can get that medication. So that now has changed how these medications are utilized. It's changed how they can treat these chronic conditions. Hopefully, they're treating them better because they have access to, everything, but it is resulting in increased costs for the plan.
So the average for December 25 was per member was $400 what? $400?
$440 on average. So that's the middle.
And what? Wow.
And
So what's the amount to get to catastrophic? Maybe what defines catastrophic?
so CMS has a calculation that they do. It's a lot of things that happen behind the scenes. It's based on the standard benefit, right? So because we have these rich benefits with group Medicare, we cover things, but the standard plans, maybe the member would have to cover those things. So that's calculated in as well. So although the member's only paying a certain amount, on the back end, they're considering the deductible that the member's not paying and all these other factors that increase that number.
So catastrophic is not $2,400.
It's not defined, it sounds like.
Oh, that really makes us.
Yeah, and that's just how,
Can they pick a different
how it's
word?
built.
Because we think of catastrophic as hurricanes. Like 2021 Ida, I'm sorry.
Yeah, and so 2024 was 8,000, 2025 it's 2,000, 2026 is 2,100, 27 will be 2,400, but the actual amount that members spend is way less than that based on CMS's calculation. And one other thing to note, because the coverage gap was eliminated due to the IRA, the coverage gap used to be a limiting factor of utilization. Members would try to keep their costs down so they wouldn't reach that gap, because at that gap, all their costs are going to go up. Well, now it's the opposite. You get that high drug in the beginning, and now you can get everything else at $0. So there's no limiting how you spend or trying to use cheaper medicines, things like that, because the coverage gap is now gone. And also in comparison to our book of business, there's 25% of members that are entering the catastrophic phase. So what you're seeing with your plan is what we're seeing across the board. And a lot of groups are having to now decide, how are we going to adjust? What's next, as you alluded to earlier.
When you talk about cheaper drugs, are you talking about generics, or are you talking about a different name bringing of a drug?
So usually cheaper is generic, a biosimilar, so something that is not the brand name, because the brand names cost a lot of money. They have to pay a lot for the research and development. They get to utilize that, reap those costs back for a period of years, and then generics are allowed to come on the market. So, basically they make their money for several years, and then when generics come on the market, we have other options, whereas we didn't, until those come available. So our tier 1, tier 2 meds are considered our, more cost-effective tiers. And we talked about how most of the prescription the members are filling are coming from those lower cost tiers. It's just the small number of tier 4 medications are just very expensive. Any additional questions there? Okay, and we're going to continue on and talk about the IRA a little bit more. So again, for 2025, there's no coverage gap. 2025, we see the out-of-pocket maximums. 274 members reached it for 2025 versus the 51 in 2024. Again, I talked about the Medicare prescription payment plan. So that's the plan that allows members to spread out their copay over the course of the year. For 2026, members are auto-renewed into that program. They kind of fall in and out based on how their payments are set up and when they pay off certain medications. We talked about the out-of-pocket maximum has, increased slightly for 26. Insulin copays shouldn't have gone up for 26. They're either $35 or 25% of the negotiated rate or benefit. So if anything, they've stayed the same for members or the prices have gone down as it relates to insulin. The bridge model is listed. Bridge model is a CMS program that's external from the plan, but it will be into effect July 2026. So this allows members who are not eligible to receive those GLP-1s as part of the Part D benefit to receive them from this government program at a flat copay of $50. Are you all familiar with the Bridge program?
No, ma'am.
Okay, so CMS initially came out with this pilot program. It was supposed to be 6 months. And then there was going to be another program that was supposed to kick in after that. Well, they came back and said, okay, this pilot program that was going to be 6 months will now be extended through the end of 2027 calendar year. So any member that does not have a Part D indication to receive a GLP-1, so like a diabetes, sleep apnea, they can be eligible to now apply for this CMS run program to get those GLP-1s for weight loss. They have criteria that they have to meet based on their BMI, based on their comorbid conditions. So do they have a prior stroke, uncontrolled high blood pressure, diabetes, and things like that. And if they meet the criteria, then they're able to get it through the CMS for $50. That will not apply to their out-of-pocket maximum. That will not apply to their benefit on our side. It's a separate program that will be available through 2027. So
I am curious with this age range, are you seeing this population of 65 and older having high utilization rates with GLP-1s?
Yeah, I think that it's similar to what we're seeing in other age groups. I think it's all the craze. And there's a lot of research being done about GLP-1s, and there's a lot of new disease states that are coming out that they're going to be eligible to get. So there may be additional Part D indications that are added as that research comes out, as FDA approves those additional diagnoses. There may be additional members who are able to access those benefits. But, we have groups that are small, large, and we're utilization is consistent for those GLP-1s. Wow. So it's been a big legislative push because they have not been able to get them because of the cost. And so this program is to help them be able to access them. And that final point on this slide was a Medicare drug price negotiation program. There's some more information in the appendix about it, but it's also another CMS program where the CMS is engaging directly with the manufacturer for those high-cost medications that don't have another source, so don't have a generic, don't have a biosimilar. So they're negotiating the price for those. So for 2026, there were 10 Part D medications that were negotiated. For 27, they expect to add 15 more Part D indications on that list. And then for 2028, they're expecting Part B, as in boy, and Part D medications to be added for those negotiations. And so in the appendix, there's additional information about that as well. So this is a Inflation Reduction Act cost implications timeline. I know this has been shared previous years. So I'm going to focus in on where we are and where we're going. So for 2025, as noted, that was when the $2,000 out-of-pocket maximum kicked in, as we discussed. For 2026, we discussed how that number is increasing slightly, but still significantly lower than it was in prior years. We talked about the maximum fair price that has kicked in for 2026 as well. We talked about the insulin copay, and then there's a lot of continued legislation geared toward this IRA push to limit prescription costs for members and costs kind of shifting away from the members. And, the plan is incurring those costs. So we'll continue to monitor those legislative pushes. And as we continue to learn more, we will bring that back and, continue to reevaluate and assess what we need to do as the industry is kind of moving in this direction. Any questions about that? Okay, thank you, guys. If there are any questions that you have, Ms. Hagewood and I will be happy to answer them for you.
So as a follow-up, we do have some takeaways, additional, and I just want to confirm with all board members that we've captured it before we leave today. Information about providing additional education on preventative screenings, recommendations as an addendum to this, let me rephrase, options that could be available to the board, 10 recommendations that could be utilized with the program. We can also look at the contribution strategy between the board and the retirees and what they're paying. I also want to make a note that last year, administration did not bring a recommendation for any cost sharing. So I just want to make sure that it's clear that we are being tasked to bring in some cost sharing recommendations for the retirees for the Medicare Advantage program.
I think we're going to have to look at all that because, when you look at our retirees who are eligible for this Medicare, they paid into Medicare to be eligible, or they buy into it or whatever. Then per month for the Part B, they have to pay approximately $200. So they are required to pay for their Medicare. I think in the past, the supplement, the Medicare Advantage, whatever you want to call it, is why we've been generous with the board to bring that on. So I think we need to be careful what we bring back, and of course we need to have a lot of discussion about it to make sure we're being fair, to our employees, because, they do pay for Part B, the Medicare of the plan, so.
Yes, sir, and that's why I wanted to make sure that I was clear in the direction. Would it be helpful, and when we bring that recommendation back, that there is a running chart next to it as we propose some options that the board can consider, that it also shows what the current CMS rate is that they're paying for the Part B?
That would, I agree, that would be helpful. I also think some of this knowledge of what the average is, because I would have looked at this as catastrophic, just the word would have sent me, would have made me think that they were spending a lot more.
I guess where I'm going with this is we forced our employees, we made a decision that they had to get off the WRAP plan and onto Medicare. I don't want to take this plan and turn it into where it would be less expensive if they stayed on our plan and not be on Medicare. We're going to defeat the purpose if we start raising, rates and so forth. So we need to be cautious when we come back to take all those things in consideration and make sure we present something that's, viable, so.
No, I agree. I think we need to look at it from big picture.
And Mr. Oakland, just to clarify, the Medicare requirements for retirees to enroll in Part B were in effect regardless if they would have been on the WRAP plan or this plan. Those requirements to enroll in Part B, that's a law that's set by the Division of Administration. So the retirees have that requirement to be in that Medicare Part B, regardless if they're on the WRAP plan or if they're on this plan. In the past, as you recall, there were some retirees who hadn't paid into Medicare because we weren't collecting that tax. And so that's why they had that population during a time period who wasn't on it. But everyone after the year of, quote me if I'm wrong, USI, 1965, I believe that we started to collect that Medicare tax. So I just wanted
1990.
1990. I just want to make that clarification that transitioning retirees to the Medicare Advantage plan did not create the payment to Medicare Part B. That has always been a requirement. And just to request some additional information, the school board also absorbs the premiums for the spouses. So I just want to make sure that I'm clear that we can provide options for both the retirees and the spouses when we consider those options, while being cognizant of what they're paying for Part B. Yes.
Agreed. I think we look at just all options, so everybody could see all options.
Thank you. Are there any other takeaways? I think we've captured everything to make sure that we can come back. As Mr. Babin stated, we should be getting that renewal pretty soon, so we will be able to provide those in-depth recommendations once USI receives the renewal for the Medicare Advantage plan. Are there any other questions? Oh, go ahead, Mr. Babin.
And we've, Darrenisha and Samantha and I have been talking about timelines, and we're going to get together timelines on both the active side and for the Medicare Advantage renewal. It's a 1/1 renewal, but, the strategies that we're going to bring forth, we'll be looking for potential vote in August, a little earlier than normal. So just kind of keep that in mind as we thinking about timelines and meeting.
Anything else? If not, I'll entertain a motion.
Move to adjourn.
We stand adjourned.
Mason, we've concluded the meeting.
I sure can.